Introduce our next speaker, and I'm gonna take everyone up to our next session, which is HPB, a topic that's very near and dear to my heart. The first speaker, I'd like to invite Professor Koto to introduce.
Japanese house speaker is Dr. Hara. Dr. Hara is graduate from Nagoya University in 1996. And after university, go to Aichi Cancer Center. Now he's the chief of gastroenterology Aichi Cancer Center. He's a specialist biliary. Okay? Okay, yes, please start.
Thank you very much from Professor Goto. Kind introduction. I'm Kazuo Hara from Aichi Cancer Center. I graduated from Nagoya University, so I'm a member of the Nagoya team. So thank you for Fuji Company. Thank you for all participants. My lecture is Intervention EUS in Aichi Cancer Center. So from now, I want to introduce my techniques. Okay, next slide. At first, this is our member. Now, all 11 doctors is our team. One from Ghana, his name is Tachi. One from Egypt. And now, Dr. Tachi can perform EUS FNB. Now he stayed for nearly 4 or 5 months, and he can perform EUS and ESFNA, but not interventional now. So my topics is EUS hepatico-gastrostomy and choledochoduodenostomy. At first, I explained hepatico-gastrostomy. Hepatico-gastrostomy and choledochoduodenostomy is much easy procedure for us because just a puncture and dilation and put stent. But until now, not so many dedicated devices, so procedures are a little bit complicated, but procedure is very simple. Puncture, dilation, put stent. So at first, I completely recommend B2 puncture. B2 puncture is most easiest, not sorry, it's the easiest procedure. So, but commonly in the world, B3 puncture is recommended. But I strongly recommend B2. B2 is very easy because B2 is very straight. So after B2 puncture, wire is a very easily insertion. We can insert wire very easily after B2 puncture. But after B2 puncture usually from the esophagus. So from the esophagus is very dangerous. So many doctors recommend B3, but I don't. This is my bad memory. So maybe 10 years ago, no. 7 years ago, after puncture from the esophagus, this patient occurred pneumoperitonitis and pneumoderma like this. So we recommend B2 puncture using forward viewing scope. Forward viewing scope is very easily puncture B2 like this. So we always put the landmark clip around each junction, and if you use forward viewing scope, you can puncture from stomach B2 safely. So this is a difference of appearance. This is a forward viewing scope. Middle scope is a Fuji 580. This is a little bit old one. Now 740 is a brand new. This is very good scope. In fact, very good scope. Yeah, 740. Yeah, and this is Olympus scope. Olympus scope is not so bad, but not so good. Yes, here. This is 260. Yes, this is a real. And already we reported this paper. This is a 740. This is これなんかあった。あ、こっち？そう。出ないですね。 So this scope is 740. This is a brand new. So tips is green. So this is a brand new, maybe now available in Japan and US and Europe. Maybe only 3 areas, but this scope is very good. Very, very good. This is appearance. This is a forward beam scope. The 740 very similar. Appearance is very similar. And bending part is also very similar with forward beam scope. This scope is a little bit old Fuji scope, 580. And this is a Olympus scope. So quite different. So if you use the Fuji new scope, you can puncture B2 easily. Maybe ratio is more than 90%. In our center, more than 95%, we can puncture B2 from stomach. Maybe Dr. Bird, you know very well. So this is also appearance, quite different. So this green is a Fuji new scope, very similar with the forward beam scope. So this scope is very good. So I recommend strongly. And puncture direction is also quite different. Left side is Fuji new scope, so perpendicularly. And 760, a little bit, can you see the difference? This is very perpendicular. So we can puncture B2 from stomach. Can you understand the figure? Forward beam scope is like this. This is a Fuji brand new scope is like this. The Olympus scope I recommend B3. So this is a real and a clinical. So, but now in Thailand 740 is not available, but maybe near future.
2 years.
2 years later? Oh, very long.
Maybe regret Fujifilm.
So this is, can you see the video? Sorry. So we can lock the wire. Very safe. I love this locking system. So if you pull back very strongly, but wire not dislocated. Yeah, this is very nice. So next topic is dilation. Maybe this is a common dilator, mechanical on the cautery and balloon and the tapered cannula. So bougie is safe, but sometimes difficult. Cautery is easy, but sometimes dangerous. Balloon is good, but sometimes cannot pass the structure. This is our younger staff. His name is Yana-chan. This video is his second case. So our young trainee. He could puncture B3 and insert guide wire deeply because this scope is Olympus scope. So B3. This is a tapered cannula, but the direction is so acute, so sometimes cannot pass. This is a very common situation, very common situation. So I invented this dilator with Asahi Intercompany. Asahi company located in Aichi, very close to the Nagoya. So this dilator is very similar with through-handler sand retriever, but quite different. Quite different. This is a very good dilator. Maybe Dr. Toi, you always
I did it.
did it.
Good.
Oh, okay.
Thank you.
So we already reported, Dr. Okuno reported this dilator in the digest endoscopy. This is a case. This is a chronic pancreatitis and very hard structure in IBD. Yes. Here is very hard, very tight structure. At first, we use the taper cannula, but cannot. But this dilator, very easily, just clockwise rotation, very easily dilated, very easily. So this dilator is easy and safe. So I strongly recommend this dilator, but I invented this dilator, so, but really, very good dilator. Maybe Dr. Bird, you know, also. This is a ERCP case. Insertion this dilator, just push, and rotation. This is second case. B3 puncture. Also, this case is a EUS HGS, but the puncture angle is very acute, you know, very perpendicularly. In this situation, sometimes dilation is very difficult. And this case is the bile duct is very small, so we use the 22G and O-white wire. We always use a diameter is less than 3 millimeter. I recommend 22G. After puncture, wire is very acute, but clockwise rotation, we can dilate the tract like this. So this dilator is maybe very good for the beginner because scope is very stable, very safe. So I recommend strongly for, especially for beginner. So time is limited, so next case is a USPD, pancreatic duct. This is a very difficult case. So usually, this is after pancreatic so surgical altered anatomy. So this is a remnant pancreas. We punctured from stomach to MPD, but this direction is very acute, perpendicularly. But pancreas is sometimes very hard. So dilation is very difficult. So in the world, many physicians recommend cautery dilator for pancreas. But the angle is very acute, so sometimes very dangerous. So this is our case. This is a cautery. So very acute, cannot dilate. And in this case, wire bending. This is a leakage, pancreas juice leakage after dilation. So after this case, I want to invent new technology or new dilator for pancreas. So finally, I invented this dilator. Oh, sorry. This is also pancreatic case. This is a 22G needle, and wire is 018. So small wire and small needle, and the angle is very acute. But if you use a Doreil dilator, we can dilate like this. Very safe. Yes, so I recommend strongly this dilator, especially for pancreas. So HGS is not so difficult procedure, so HGS is not necessary. But pancreas is sometimes very dangerous and difficult. So I recommend Tornes, this dilator. But disadvantage, some disadvantage. So this is the coil sees. So cannot injection and cannot aspiration. Yeah. And tips is not so hard. So we should adjust the direction like this. Of course. And sometimes, so this tips is a little bit big. So plate dilation is sometimes useful if procedure is difficult. Finally, I want to mention the stent. So I always use fully covered, because I want to perform re-intervention easily and safely. So I recommend fully covered metal stent, and diameter is 6. 8 or 10 is too big for intrahepatic bile duct. Just my opinion, but so I recommend 6 millimeter, 12 cm, Hanaro benefit. Hanaro benefit is a very small device because the CC is 5.9 French, very small. So usually no need dilation. But this metal stent is very soft, so sometimes bending in the abdominal cavity after stent placement. So I recommend put clip. Put clip like this on the stent. So this clip prevent internal migration. Yeah? But fully covered metal stent sometimes broke to the peripheral bile duct. Can you see? This is after HGS. Contrast still remain in the peripheral bile duct. So this is a problem. So recently, we make the side hole by myself. Already we reported. Yeah, already we reported. Not so difficult. Yes. And the length is 1.5 cm. Open the stent and puncture the membrane using aqua needle. This is a handmade, partially side hole stent. No, not commercial available. Yeah. So this stent is very good. So after HGS, contrast disappear. All cases. And most important things, removable. Removable is very important for me because re-intervention is easy. So partially covered metal stent, sometimes not removable. So I recommend these techniques or this style for the patient. And sometimes Asian doctors said to me, plastic stent is good or not? Because the plastic stent is cheap. But my answer is plastic stent is not so good. Sometimes bile juice leakage along the plastic stent. Of course, not all cases. So mainly maybe no problem, but sometimes. So I don't recommend plastic stent at first. Re-intervention after fistula creation, plastic stent is no problem. But at first, I recommend fully covered metal stent, just in my opinion. So this is our procedure. First, using 740. 740 is good, really good. Really good. Yeah, but this time 740 is not available. So I want to use this time. Yeah, really, yes. Yes. And puncture is puncture duct diameter is less than 3 millimeter. 22G is recommended because very easily puncture. But diameter is big, of course 90G is enough. And dilation sometimes use the tallness. And finally, stent is fully covered metal stent and handmade side hole. Next topic is choredoco duodenostomy. Choredoco duodenostomy is very easy. So just I want to mention it briefly. So needle is an acquire needle, 20G needle. Why acquire needle? Dr. Okuno has reported. This is a Olympus FNA needle, 19G. And next is a Boston FNB needle, acquire. Can you see the difference? It's very big hole. So if you use acquire needle, we don't need the dilation because the hole is big. Already we reported. So we puncture the CBD and inject. Now, can you see this is a metal stent. We don't need dilation. And finally, we deploy the stent in the duodenum, just 5 or 10 minutes, because non-dilation, so no leakage, just 19G and metal stent. So same step if you use Axius or Lumiapose metal stent, because just wire stent, same step. Yeah, very safe. And after 3 months later, we remove the stent because we want to make the permanent fistula. Permanent fistula is better for patient because stent is not needed. 70% patient, we can create a permanent fistula, but 30% cannot. This is our data. So take-home message. For easy and safe interventional EUS, to understanding technical tips, and select and prepare the effective device and scope. Scope is very important now. Yes. So thank you for your kind attention.
Thank you so much, Professor Hara. We'll keep the questions at the end. I know a lot of people have questions in their mind for you.